Hi, my name is David Smith, and we've got our friendly skeleton here to show you something about the hip. I do a lot of hip replacements, and I know when patients come in sometimes there's some misunderstandings about how we do a hip replacement. Basically, you start with the human anatomy, where it exists on your body. In the groin area here, it's the ball and socket. It's deep in the body, surrounded by large muscles. And approaches are how we get in there to do the surgery of hip replacement. Today I want to just talk about some of the options you might be thinking about if you are going to have a hip replacement, how you can have some information, know if you have a preference, whether you want it done from the front, the side, or the back. So we started with looking at the bones only, and we're going to go over here and look at something that reflects a little more of the reality of the surgeon's life, and that is, how do we get through these muscles to get into that bone? I've, for the past almost 10 years, have used exclusively the anterior approach. And anterior means front of the body, posterior means back, and this is lateral. There's three general ways done. The most frequent in the United States is a posterior approach. And this is the back of the human body. You can see the shape of the buttock muscles here. And what's done is we have to go through this large muscle to get down to the joint itself. It also involves cutting into these external rotators. And the downside of that is it can weaken the back of the area and make it more susceptible to a dislocation. Now, that's not to frighten people who are going to have a posterior. That's an excellent way of doing it. For a number of years, I did the posterior approach. Total hips are the most successful operations, so whether it's done posterior, anterior, or lateral, those are certainly reasonable approaches. But you do have to go through a larger muscle, and I've found, because I've done all the different approaches, that with my anterior approach, I've found patients seem to progress more quickly, have less pain than I saw in the posterior approach. There's a lateral approach, which I also have liked through the years. The problem there is these strong muscles called abductors that really hold you up when you walk. Part of those have to be taken down, and even though we repair it after the surgery, it can result in weakness. In some patients, if this muscle is weakened, might require long-term the use of a cane. So that's the downside of that. The anterior approach basically takes advantage of the fact that these muscles in the front, we can easily go in between them and get right to the hip. With the anterior approach, we take advantage of this muscle, the tensor, runs up and down, sort of a vertical. The sartorius runs the same way, and we can take advantage of that and go right between those two areas, and it'll get us right down to the hip, which is more of an anterior structure than it is posterior. So we don't have to cut any muscles or separate any muscles, and it brings us right down to the capsule. What we're doing when we get there, just to kind of show you the preparation that's done, once we've exposed this cup, which is part of the pelvis, if you feel along your belt line, you'll feel this prominent bone, the iliac crest. We're going to put in a new liner with a plastic liner with a metal shell, and that goes right into the acetabulum. Through the anterior approach, I found I can get that lined up better because the patient's laying on their back. We can use fluoroscopy or x-ray to visualize it, and I think that does help. On the femoral part, or the thigh bone, basically what we're doing is taking advantage of the normal canal that exists in the femur, and we machine that so we can put these devices down. Now, this is a model of the device I use. It's called the Karai, and it's a cementless, so there's no bone cement. Bone grows into it. We impact that down in there, and then it articulates and replaces the worn-out hip. These little models here show what a normal, healthy cartilage should look like, and there should be cartilage in this horseshoe design on the inside of the cup, and that's what the head should look like, nice and smooth. This is what happens with arthritis. It wears off. So basically what we do is remove the worn out head, smooth off the inner side of this acetabulum or cup, put in a stem, join it back together. Then we let these muscles, tensor fascia muscle, the sartorius, come back together. The rectus falls over that, and we just close the skin. So that's the 3 common approaches: anterior, which I favor, lateral, and posterior. I hope that answers some questions you might have about hip replacement and how they're done. There's some more information on our website, boneandjointworld.com. On there we have several webinars where I use some slides. We talk about the anatomy and we talk about the approaches to the hip. In addition, there's opportunity for you to leave some questions, and we'll try and either through doing another one of these webinars or through doing a podcast to answer your questions. So join us on the website. We'd be glad to try and answer any questions we can. Important thing is talk to your doctor, but this is just to give you some general information that there's different options, and you may ask your doctor why he prefers one approach over the other.